a diver who was on Trimix. He was paralyzed from the waist down, where we treated him with the U.S. Navy Table 6. And at the end of all that, he required to ambulate with 2 quad canes for the rest of his life. This diver had contacted me a few months later, and he called me up and he asked me a very important question. Dr. Charash, when can I dive again?
Hey everybody, Joe Cocozza, and welcome to a special video podcast on this week's Pod Diver TV. This is going to be about diving fitness and diving medicine. And I'm here with Dr. David Charash, who is a diving medical doc. And I'm going to let David pretty much tell you about his background, but let me just quickly mention, David's got 28 years of hyperbaric medicine experience. He was in military, commercial, public safety diving. He was the medical director of a hyperbaric program at a hospital. He's a Dan referral physician, and he's a certified dive medical fitness examiner. And we're going to talk about what that means. So first of all, hey David, welcome to the show. How's it going?
Joe, it's really great to be here. Thanks for inviting me.
Well, we spoke actually at DEMA this year in 2025. We were talking a little bit about this, and the idea you were talking about is on diving, tech diving and the aging diver and a few things, but I really think as the years go by, we really need to start focusing more on diving fitness and what is fitness for diving in relation to diving physiology. So we're going to get into this episode. We're going to be covering a bunch of subjects from what really fit to dive means and a bunch of other things. But before we actually dive into this, I just want to say to all our viewers, please, if this is the kind of content you like about diving fitness and diving medicine, if there's other subjects related to that, please put a mention in the comments section below. And as always, to keep us providing this kind of content for you, hit that like and subscribe to the episode and share it with a dive buddy. So David, tell me a little bit about how you got into diving and became a diving doctor.
Well, I got into being a diving doctor before I got into being a diver. So 1992, I was completing my residency in emergency medicine. I was also just finished my training in hyperbaric medicine, and now I was on call one night as a hyperbaric doctor covering any diving or hyperbaric emergencies, and I received a phone call about 10 o'clock at night from the Coast Guard. They were air evacuating an injured diver from the Great Lakes into the emergency department. A diver who was on Trimix, he surfaced, he was paralyzed from the waist down, so serious decompression illness type 2. My examination briefly showed a paralyzed diver from the waist down, awake and conscious, but in real distress. I did a quick medical evaluation, stabilized him, and transported him to the hyperbaric unit, where we treated him with the U.S. Navy Table 6. So that was about a 5 hour treatment protocol. Because he still had persistent symptoms despite the treatment, we did what's called an extension. So we gave him an additional hour of hyperbaric treatment, and we admitted him to the intensive care unit. He still had persistent paralysis below the waist. He had subsequent 3 other additional hyperbaric treatments with no improvement. He then went on to receive occupational and physical therapy. And at the end of all that, his illness was persistent, where he required to ambulate with 2 quad canes for the rest of his life. Wow. Now, that was my first experience managing an injured diver as a non-diver.
And you still got into diving?
Well, it took a while, a little bit of convincing. But that experience was so profound. And in the 3 years of my training in emergency medicine and additional treatment protocols for diving injured, I really became fascinated by this diver, by the way, had contacted me a few months later, and he called me up and he asked me a very important question. Dr. Charash, when can I dive again? Now, this is a guy that's still partially paralyzed, can't walk on his own, has to use quad canes. So I became fascinated with the psyche of the diver, the diving gas laws, the physiology, the role of hyperbaric oxygen therapy. And that really began a over 30-year career in dive medicine. And I'm still asking the question, why does this happen? What can we do to make this better for our patients?
Wow. So that's how you got into you were basically doing diving medicine before diving.
That's correct. And when I moved from Michigan, Detroit, where I did my residency, to Connecticut, I was very interested in opening up a dive medicine practice, and I started a dive education program for the community. And a mentor of mine, Nick Bird, Dr. Bird, he said that if you want to have the credibility as a dive medicine physician, you really do need to be a diver. And I really thought about that, and I said, you know what? I need to get my training. I need to get a better understanding of what divers go through. And then I started out as a, recreational diver, basic, advanced, rescue diver, dry suit. And I continue to dive because I need to understand what you as a diver go through. I can put a hard hat on. I know about rebreathers. I know about Trimix gases. I know about these things because when you come to me as a diver, I'm your dive physician. I need to be able to relate to you and understand why this condition, this decompression illness occurred, and what I could recommend to you to help mitigate that risk from it occurring again.
And you talked about Dr. Bird. He used to be the physician with Dan. I interviewed him. I'll put his interview audio podcast in the links there below. But he was also a former Air Force flight surgeon, and weren't you former Air Force?
Yeah, so Dr. Bird, a great mentor. He was also president of the Undersea and Hyperbaric Medicine Society. And I just give him a little bit more kudos because he was also one of the key members in formulating the newest recommendations for the recreational medical fitness guidelines in 2020 with a number of other great dive physicians. Okay. And yes, he served in the Air Force. He was a flight physician. And I was in the Air Force. I actually joined the service when I was very young, and I was an aircraft mechanic fixing planes. And at some point I realized that the hydraulic fluid that was going into the various actuators and pumps kind of mimicked blood, and the pumps were like a heart. And then I kind of said, well, maybe I should become a physician and fix people instead of planes. So I kind of went from a aircraft mechanic to a people mechanic.
Okay, so we're going to talk about people mechanics now. Dave, what does fit to dive really mean?
Well, it's an interesting concept, but it's pretty straightforward. There are actually 6 components to fitness to dive. Medical fitness, which we'll talk about in some detail, but there's also psychological fitness, nutrition, physical fitness, knowledge, and physical skill. It's really the combination of all 6 that qualifies one to say I'm fit to dive. When you think about fit to dive, though, it really depends on the kind of diver you are and the kind of work requirement you have. What I mean by that is that if you are a recreational diver diving in warm water at 30 foot, single dives on an air cylinder, compared to a tech diver with a 300-foot depth of diving, penetration into a wreck, and then having to do deco dives, you can see that the requirements to be fit to dive on the psychological aspect, nutrition, physical fitness, skill, knowledge, and medical fitness are clearly different. And so it's really important that we understand what it means to be fit to dive, and that also that I might be fit to dive today, but tomorrow I may have developed a new condition, a medical issue, or an illness that, at least for this moment, makes me not fit to dive.
Okay, so let's talk about a few things. We're talking about divers aging, things like cardiovascular screening, BMI and fitness, those kinds of things. Let's talk a little bit about that, and then we can segue into like women in diving and kids
Sure.
and stuff too.
Yeah, so I think the most important concept is that at any age, we're all aging divers for the most part, right? And as we age, we start to develop conditions that may put us at risk. So the first part is that as we age in and of itself is not a risk factor for diving injury or diving accident. However, as we age, we typically start to get some baggage, right? We start to get a little maybe overweight, deconditioned. We may have some medical conditions that may put us at increased risk for a diving injury or diving accident, and that medical condition can get worse as a result of diving. But diving in and of itself is not going to give me a medical condition per se.
Okay, I want to take this in three different directions. One, let's talk about cardiovascular fitness. Two, also as we get older, and I'm a prime example of this, as a weekend warrior, orthopedic injuries and how that affects you as you get older and how fast you heal from those. So let's first tackle that first one, cardiac issues and as you age.
Sure. So a dive physician, when giving a talk or meeting divers, the last thing they want to talk about is a diving fatality, right? Because that's a startling concept. Mm-hmm. But I would like to kind of start the conversation with diving fitness and cardiac fitness, and I think that's where we're talking about. But keep in mind that when you look at diving fatalities, the thing I said we weren't going to talk about, that Divers Alert Network in their literature on diving fatalities found that there's about a 28% incidence of cardiovascular disease in those divers who succumb to death while diving. So 28%. So roughly a third of diving fatalities have an associated cardiac disease or cardiac illness.
Wow.
So that's a lot, right? That's a third. Now, having said that, that's something that we can mitigate if we understand that concept. Now, the average age of diving fatalities increases after beyond the age of 45 to 50. And as you continue to age 55 to 60, 65 to 70, so the older we get, we have an increased risk of having some cardiac event if we have cardiac disease. Now, the interesting study, and this is part of this aging and diving, but age in and of itself is not a risk factor for a cardiac illness, injury, or death. But if you have cardiac disease and you're getting older, then you're increasing that risk. So one of the things we have to understand then is what are our risk factors for cardiac disease, and can we identify them, mitigate them, and lower our risk? And the answer is yes to some of that. In other words, that if you have one of the risk factors is having a family history of sudden cardiac arrest in a young family member. So if your mother, father, sister, or brother had a cardiac arrest at age 50, that's a young age, then you have that same genetic potential predisposition. You can't change your family history or the genetics, but what you can identify are other cardiac risk factors, including obesity, so weight reduction, good nutrition, smoking cessation, elevations in lipids, lipid profiles, hypertension, diabetes. Those are sort of the big cardiac risk factors. And what dive physicians are now looking at is something called a Framingham risk score, which basically risk stratifies you into either sort of high risk, middle risk, or low risk. And by evaluating your cardiac risk, you can start to look at those risk factors and then determine of those risk factors that you're identifying, are those conditions that you have a relative risk or an absolute contraindication to dive. And I think before we can talk about that, we have to understand that a definition of a relative risk is having a disease entity, let's say hypertension. If I have hypertension and I'm on appropriate medication, my blood pressure is controlled, I have no other relative medical conditions, I still have a relative risk for potential diving injury or diving accident per se, or worsening of my condition while diving, relatively. But it's a low risk because I'm well controlled. But if I have that same diagnosis of hypertension and the blood pressure is not controlled, I'm not on appropriate medication, that risk may put me at an absolute contraindication to dive because the risk is so high. So what we're really talking about when we're talking about cardiac fitness and risk mitigation is lowering the risk to the lowest certainty point of having an injury or accident or having a complication of a medical condition while diving.
Another part of diving, and you're originally a Northeast diver yourself, so we all know what it was like to get on those rocking dive boats, is orthopedic injuries as you get older. And as you get older, and especially as you're staying active, those things happen more. And the issue is, okay, it's one thing this happening on dry land. What happens when you get an injury underwater? So let's talk about, as you get older, orthopedic injuries and how that affects your diving profiles.
Well, sure. And again, it depends on the kind of diving you're doing, right? For example, if you're diving doubles, right, and you have orthopedic injuries, that's going to increase the strain on those orthopedic injuries versus if you're in warm waters on a dive boat where you have a dive master who attaches all the equipment to your back while you're sitting on the dive platform and gently pushes you off the dive platform in warm water as you're, doing your dive for the day. So different stressors, right? So I think you have to look at the individual, what that orthopedic issue is, and then decide on trying to mitigate the repetitive trauma that's causing aggravation of those underlying causes. Now, I recall one of my dive buddies, she had bilateral 2 shoulder replacements, 2 knee replacements, much older person, right? And she could not carry any of her dive gear, but her passion was diving. She was not going to give up diving. And so the compensation to help her get through that was to hire someone to carry her gear, help get her gear on, and help get her gear off so she can continue to dive. Because once in the water, being neutrally buoyant, she was like a jellyfish, right? She just could go in and enjoy and be
I think
safe.
I know who you're talking about.
Yeah. So the point being that can become each and every one of us at some point.
Well, I would see her around Ginny Springs in her scooter.
Yeah.
Yeah. So.
Well, and they're everywhere, unfortunately. As we age, we start to replace our parts, and then we have to sort of decide at one point where, maybe it may not be so safe, or you have to change your dive profile based on the lack of ability to carry out the task at hand.
Okay, I'm going to want to go in a slightly different direction before we get to the next question. I think my really deep Trimix diving I'm over with, just because of of all the extra risk factors with DCS and things like that. So let's talk a little bit about that as you get older, decompression diving and things like that, and that kind of stress.
Well, I think that Neil Pollock, who's a diving physiologist, a really brilliant guy. He's very active. He's residing in Canada. He was affiliated with Divers Law Network for many years, a great researcher.
I'm going to actually, I did an audio podcast with Neil, and I'm going to put that in the description below. People can link to that.
So he has spoken a lot about and done research on what's called decompression stressors. So decompression stressors are those things that could potentially increase your risk for getting decompression sickness. And when I think about decompression stressors, there are literally 1,200 or more of these decompression stressors that we know of, and probably many more. Those decompression stressors can be things like temperature of the water, whether you're hydrated, dehydrated, exercise before or after, whether you're obese with lots of fat, for example, if you're tired, if you have a fever, infection, for example.
Aren't orthopedic injuries part of that too?
Well, that's stress, right?
Yeah.
Stress on the joints, right? The extra effort that you would have to lift and carry things, right?
Yeah.
If you have an acute injury in a shoulder, when there's fresh blood from a tear and you decide to go diving, right? Whether it's a recreational dive or a dive with decompression, what happens when you start off-gassing is the disruption of the blood flow because of the acute trauma can sort of make a nitrogen bubble expand in that area, and you then can either have decompression sickness as you come up because of that traumatic event, or equally as confounding can be, is it decompression stress or is it my shoulder injury because I had a torn muscle in that area as I come to the surface? So the answer is that when we're diving in decompression or technical diving, I think we just call it technical diving, the decompression stresses are far greater. The deeper we go, the longer we stay, the more equipment we have, the more challenging the dive, right? The longer we stay underwater, those decompression stresses can potentially increase our risk for decompression sickness. And therefore, as a well-educated diver, whether it be technical or recreational or public safety or whatever diver you are, is to try and understand what are the risks based on the elements of my dive, what is going to be my dive profile, what are the decompression stressors, what are my risk factors for the day. For example, if I woke up hungover, dehydrated, I'm already walking into potential risk, increased risk. What can I do to mitigate that risk? Or, in a certain sense, should I call the dive for that day?
Well, Dave, we did talk about diving fitness, but let's talk about what happens when things go wrong. So let's talk about diving accidents now. And since you've treated real-world diving accidents, just give us a little bit of your insight onto that.
Well, I know it says diving accident as if it just woke up one day and it happened. But in fact, diving injuries occur as a result of violation of the gas laws. Now, having said that, we can push those gas laws significantly when we have undiagnosed or untreated medical conditions. Now, when we think about the traditional classification of diving injury, we think about either decompression sickness or arterial gas embolism. But there are other medical issues that can occur while diving, including things like pulmonary edema and drowning and barotrauma, and there's a long list of things. But let's for a moment talk about decompression sickness versus arterial gas embolism. And I'm going to include slides that your group can look at. This is slides that is courtesy of Dr. Simon Mitchell, another brilliant dive medicine physician. And in one arm of this, we have the dissolved gas that goes either into the venous blood or the tissues, and we get decompression sickness. And on the other arm, we have pulmonary barotrauma. Typically, breath holding on ascent is the most common cause of pulmonary barotrauma. And then the air itself goes into the arterial blood. That arterial blood typically goes to the right heart circulation, often to the brain, and we have something called an arterial gas embolism. In both cases, we have either nitrogen bubble or air, and following the gas laws, as we surface, that bubble gets larger, expands, Boyle's law, and if it's impinging a joint, we get joint pain, decompression type 1 sickness. If that bubble impinges a blood vessel, let's say if it was in my artery in my neck, the carotid artery, it causes inflammation in the blood vessel, and because there's blockage of blood flow, because you have this big bubble.
Can it be also in your lymph system where you get like skin bends and things like that?
Yeah, I mean, basically the nitrogen bubbles or the gas bubbles, because it can be nitrogen, but could also be helium, right? Because that's another gas,
whatever diluent
right?
gas you're using.
Right. So those bubbles, wherever they go, will give you different symptoms. So if those bubbles, for example, nitrogen or helium, goes to your inner ear, you get inner ear decompression sickness. If those gas bubbles go to your joint, you get joint pain. If it goes to the lymph system, you can get lymph enlargement, so your arm could swell significantly. If it goes into the lymphatic channels into the skin, you can get what's called cutaneous manifestations or skin decompression sickness. So it can go in any part of the body. It's an issue where it depends on where the luck of the draw is, how many bubbles come out in solution. So if you have a lot of bubbles coming out of solution, they can overwhelm. These nitrogen bubbles typically go through a filter in your lung called the pulmonary filter. And if you get overwhelmed, those bubbles can end up in your lungs and you can get pulmonary decompression sickness. So depending on where the bubbles go will give you different symptoms, and the symptoms could be either mild, joint pain or skin, or it could be serious where it includes things like your heart, lungs, nervous system.
DCS, in a way, I think you can manage, but the thing that really scares me is those pulmonary barotraumas. Now, let's also talk about something I think maybe is this a rising issue? Pulmonary edemas.
It's called immersion pulmonary edema, right? So what is immersion pulmonary edema? So let's imagine your body. We immerse it in a tub of water, but your head is above water. All the pressure in the water, including the atmospheric pressure above, right, is putting pressure against the body. That's called hydrostatic pressure. That hydrostatic pressure, because it's increased because the body is submersed underwater, is pushing the fluids in your tissues to the core of the body. So I have fluid circulating around, plasma, okay, fluid, in my arms and my legs. And under hydrostatic pressure, the physiologic aspect of that is as the fluids get pushed to the core, and if I have too much fluid going to my core and to my heart and the lungs, it could go into the lungs, and I end up with something called pulmonary edema, so emergent pulmonary edema. Now, we see this in divers, but we also see it in swimmers, something called swim-induced pulmonary edema, or SWIPE. We see this in young, healthy athletes, Navy SEAL in BUDS training in San Diego. As they're swimming, very healthy people, they suddenly start coughing and having shortness of breath because they're developing the fluid moving into the core, even though they don't have any underlying heart conditions.
Wow.
In the diving world, the common findings are for someone who has emergent pulmonary edema it typically happens in colder waters, in divers who may have unknown or known heart conditions. And the symptoms of emergent pulmonary edema typically occur starting at depth. So I dive to 60 feet, I'm in my dry suit, I'm comfortable, and then suddenly I start feeling a little short of breath, maybe a little chest pain. I start coughing, I become anxious because I don't know what's going on. I start to surface, and as I surface, I'm getting worse and worse. My condition is worsening. Hopefully I don't panic or make a rapid ascent, but this is what can happen as a triggering event to something that can become catastrophic, like arterial gas embolism because of rapid ascent. When I come to the surface, I look like I'm having a condition called congestive heart failure. All the fluid is backing me in my lungs. When this occurs on the boat, for example, the team should recognize the dive profile. The history was symptoms occurred at depth, got worse when it came to the surface. And the first thing that should happen is, after you assess the divers, get them on some oxygen, get them out of their tight clothing, have them sitting upright in a more comfortable position wherever they're comfortable, get them on the oxygen, calling 911, getting help and getting to the nearest emergency room, and then having them evaluated for what looks like emergent pulmonary edema. Now, the difference in thought here is it emergent pulmonary edema versus is it decompression sickness involving the lungs, so pulmonary decompression sickness? Because the symptoms can be the same. The symptoms of pulmonary decompression sickness are coughing, chest pain, shortness of breath, and edema that can come out of the mouth, right? We call that frothy sputum. The difference is that emergent pulmonary edema typically starts to occur at depth and gets worse when you come to the surface, whereas pulmonary decompression sickness, you have no symptoms at depth, right? Because based on the gas laws, you're not having decompression sickness. But when you have a change in ambient pressure and you come to the surface, as you surface, depending on how long you've been underwater, your symptoms begin as you're surfacing or once you surface. So just by understanding the dive profile, did it happen at depth or did it happen on surface, you can differentiate one from the other. But the initial emergent treatment is going to be the same. It's going to be oxygen, get him comfortable, call 911, get him to the nearest emergency department.
And the reason why you're one of the diving medical referral physicians is because you understand these issues. This way, even when you do contact the 911 system and you go to they actually have a doctor that they can talk to at DAN who can explain to them, this is a diving thing, because, your average ER doctor is probably not going to be as knowledgeable as you were when you were in ER and you handled that hyperbaric emergency. So it's good that they have that resource and be able to call Dan and get an expert like you on the phone to talk to that other doctor to explain, okay, this is what, as far as like evaluating that symptom. You're evaluating that symptom because which is it? Well, the doctor needs to know to ask that right question. Did it have it at depth, or you felt good at depth, but when you came up, that's decompression sickness.
Right.
You felt it at depth, it was probably an edema. So,
and the reason that's important, first to clarify 2 points. One is that yes, it's great to have the Dan insurance, but you don't have to have Dan insurance to call Dan. Divers Alert Network will be available to any person who calls for free on the 1-800 number to help guide your treatment. They also have the ability to help the emergency room department or the hospital decide where the nearest treating hyperbaric facility is. And they can evaluate and help in that process. So that's important. Now, having said that, the reason why it's so important to differentiate between emergent pulmonary edema and pulmonary decompression sickness is because the treatment for emergent pulmonary edema is oxygen, put them on a heart monitor, give them medications to help get rid of the fluid or diurese the fluid. So a diuretic, sometimes morphine, and then evaluate the heart to make sure they didn't have a heart attack, and then do further evaluation to look for an underlying disease. Remember I said that majority of these patients who have emergent pulmonary edema have either known or unknown heart disease. So things like echocardiogram, stress testing, evaluation for heart attack are to be done. And then the other part of that emergent pulmonary edema, just to complete the story on that, is that if you have been diagnosed with emergent pulmonary edema, you have an increased risk of having a second episode of emergent pulmonary edema. Now, a recent paper in the South Pacific Underwater Society kind of evaluated and made recommendations, and they kind of feel that if you've had an episode of emergent pulmonary edema, that you may not want to dive again. In some circles in dive medicine, physicians will evaluate a patient, make sure from a cardiac status that all things are identified and mitigated as far as cardiac disease, and inform the patient that they're at great risk for having a second episode of emergent pulmonary edema. If they have a second episode of pulmonary edema, then they would recommend no further diving.
Is there any specific age when divers should get a cardiac stress test? Or is it, something that young divers should even do? I don't know.
Yeah, so the answer is, I think, as a general discussion, you shouldn't get a screening test at any age for any reason, right? You should have a test for a specific reason if you're looking for a specific condition. So, for example, when we look at the Recreational Scuba Training Council guidelines for cardiovascular fitness, they talk about the role of a stress test when clinically indicated. They want to look at your exercise capacity. And the things that they do with the stress test looks at a few things. First off, it looks at an electrocardiogram in real time as you're doing exercise, going up a treadmill over time. It also monitors your blood pressure as you're doing these performative exercises. It also is assessing your heart rate and your symptoms. So, are you having shortness of breath? Are you having chest pain? And then it's also evaluating something called metabolic equivalent tasks, METS or METs. The METs basically equate to what is your exercise capacity for a given minute in time. And so an example is, you and I are sitting on a chair talking to each other. We're probably expending about maybe 1.5 METs just sitting there. If we were doing some gardening on our knees, weeding, that's probably maybe 2 to 3 METs. If we are swimming a mile in 8 minutes, that's probably about maybe 13 to 14 METs. Now, that when you do the stress test, for example, I may be able to get to 13 METs, so I'm really doing really well, but I only can do it for 10 seconds before I become short of breath and have to stop. Why is this so important? Because the physical capacity for you to be able to complete a task is kind of the key question. So, for example, I'm diving. I've completed my dive. I'm on a dive boat. I ascend, and the boat is 200 yards. I have to swim there. how much energy do I need to expend when I'm using my kick to get to the boat, right? And what happens if, when I come to the surface, suddenly the winds pick up and I have 2 to 3 foot of chop and there's a current? How much more energy do I need to expand? So for a young, healthy person who has good buoyancy and is got good physicality, physical fitness, probably not much of an issue. But think about an older diver that may be deconditioned, that might have some underlying heart disease.
Yeah.
Do they have the exercise capacity to be able to get from point A to point B in those conditions? So the stress test can help measure that physicality, if you will, the metabolic equivalent. And the current guidelines and recommendations for a recreational diver is 6 METs or greater. So 6 METs isn't really a whole bunch of energy that they require. But think about what kind of amount of physical energy you would need to have to be able to swim 200 yards in chop, current, and winds.
You know, yes, if you're doing a nice drift dive, everything's easy, but you still have to have the capacity when things go wrong.
Correct.
To be able to swim against the current, get back to the boat. As you know, being on the ocean, I mean, it could be a flat as a lake in the morning, and an hour later you're in 6-7 foot choppy seas. I had another question about tech diving and the physical demands of it. What are the physical demands of tech diving, and so are we underestimating the physical demands of tech diving compared to recreational diving?
No, I think the challenge, of course, is, and I just want to clarify, when we talk about fitness to dive, we have recreational divers, right? We have commercial divers, we have public safety divers, we have scientific divers, and we have military divers. But there is not a real classification for medical guidelines for technical divers. They still come under the classification of recreational. So I want to take a step back, if we could, in understanding then the standards for medical fitness requirements for each of the different classifications. In the situation where we have recreational divers, right, the guidelines were designed to be inclusive, to be educational for the diver and for the doctors examining the divers. So we can know that because you're a recreational diver and you might have hypertension, diabetes, obesity, 2 shoulders and 2 hip replacements, that you still should be able to dive if you have certain medical stabilities. But if you are a scientific diver or a commercial diver, a military diver, they have very restrictive requirements, right? So you cannot be a commercial diver if you have had multiple joint replacements, if you have hypertension, diabetes, and your multiple indications. That would be a absolute contraindication for a commercial diver, whereas a recreational diver may be allowed to do so. So those medical conditions can be cumulative and increase the stress when diving. So if I'm a technical diver, the guidelines for medical fitness are that of a recreational diver. And so when you go to your physician for clearance to dive or fitness to dive, he's going to or she's going to use guidelines for recreational divers. But as technical divers, you're absolutely correct, Joe, that there is increased demand and workload and work requirement for technical divers. That equipment increases the workload, right? Your situational awareness has to be much higher. Your physical skill, your physical fitness, your nutrition, your game, right, has to be much higher at a higher level than a typical recreational diver who's diving in warm water at 30 foot with a single tank. So do you have the physical fitness, the psychological fitness, the nutritional fitness, the physical skill, and the medical fitness to complete the task safely as a technical diver? That's the real question.
I mean, just on basic cardio, I just did a 90-minute, not even counting my deco, but I was swimming for a solid 90 minutes.
Right. Right.
Yeah.
And so that's your exercise capacity, right? And, you know, if you had, let's say, hypertension, and it was uncontrolled, think about the stress on the heart, what potentially could happen. And if you were, did a typical cave dive, you'd drop down to 40 feet, but you penetrated 2,000 foot, and you're doing your deco, right? Because I think that's kind of the diving you're doing lately. What would happen if your heart started beating erratically, chaotically, while you were on your deco?
Yeah.
Because of the increased stress that you gave yourself.
Well, that's actually, I think, a good way that we can segment into mental fitness and decision making, because a big part of being an advanced diver, whether you're recreational, technical, or commercial, or scientific diving, is that mental fitness. I just did an interview with Chief Rick Batua, who was the youngest U.S. Navy master diver ever at the age of 32. And he did 32 years in the Navy. Interestingly enough, he was at E9 longer than he was at E1 through E8. And had a great story. But I asked him what every diver should, what's the one philosophy that every diver should have? And he said, stop. If you get into an issue, stop, think, and act. So how does that affect mental fitness underwater? That whole attitude of handling stress and panic and psychology underwater.
Sure. Well, I think that begins above water. So, for example, I was thinking about this because I'm from the Northeast. In Connecticut, we had 2 foot of snow, snow drifts. They closed the highway. So I had to get out. I had work I had to do. So I woke up that morning. I looked out the window and I go, I don't know. It doesn't look good. And I made a couple of phone calls and I realized the highways will close, the roads will close, nothing's plowed. So I made a risk assessment. So I stopped, I thought, and I had to make a decision. Do I go or not go? I didn't go, right? Well, I do that every time I go diving. I might be medically fit today. I might have some anxiety or depression or other phobias. I think we all do at some point. I leave the house. I get in the car. I have to get to the dive site. Before I put my fins on, I have to make a risk assessment, like I did when I was in bed looking at the snow. Do I leave the house? Do I put my fins on? Am I anxious, depressed today? Is my thought process okay? No different than when I would say, my blood pressure was high 3 days ago and I haven't been on the medicines for a week. Maybe I should reevaluate my risk assessment for that moment. So that stop, think, and act is a very appropriate decision point, not only underwater, but before you get in the water. So making that assessment, I feel good, I'm fit in my mind, I'm fit in my body, and now I can put my fins on. And then you make that same reassessment once you're out in the water, and you decide that when you look up, suddenly the conditions may not be perfect for you to be a safe dive for that day. Now let's say you're underwater and you've never panicked before, but you realize that you're starting to leak some air from your cylinder. You get a little anxious. Your respiratory rate's going up. You're starting to panic. So that stop, think, and act is a very appropriate thing to do at that moment because you're having anxiety. Anxiety is increasing your respiratory rate, which is increasing your air consumption, and you know that your air is leaching out. So what do? Again, as you're whether you're a solo diver or not solo diver, you're calling for help, right? You're making a decision what I need to do at that moment to be safe. Stop, think, and act, I think, is a great process for a quality, safe dive, whether it's above or below water.
I think in a corollary to that, something we learned definitely learned in cave training and a lot of technical training, is also when you're diving in a team, any diver can call the dive at any time for any reason.
Right.
And sometimes it's just those, and I'm shaved head, but those little hairs in the back of your neck go up and go, oh, for some reason I just don't feel right. this isn't. I'll give you an exact example I had. This was about 10 years ago. I'm diving on the Jersey dive boat, and we get out there, and my breather was just had one problem after another, right? So I finally get everything working, and then I'm putting my dry suit on. My dry suit wrist seal rips, and I'm like saying like, okay, I actually did bring a semi-dry suit with me, and I could have like, I said at this point, so many things have gone wrong. This is not necessarily like a physiological or health thing. It's like so many things have gone wrong today. I just basically said, you know what? I'm just gonna like take this one, and I'm gonna take a nap in the cabin of the boat, and that's it for today. I just, for whatever reason, I decided not to dive that day because just like so many things were going wrong, and I just said, for some reason, maybe the universe is telling me not to get in the water today.
And I think that's a great story, because think about what would have happened had you have dove that day and had second thoughts as you were descending, thinking, you know what, maybe I shouldn't be here. Well, oh, it's okay, I'm here, but maybe I shouldn't be here. Again, you need to be in a positive mindset at all times when you're diving, with a clear thought. And if the thought is, maybe I should call it, then that's a good thought.
So the next thing I want to talk about with you, Dave, is chambers, hyperbaric chambers, and taking chamber rides and Navy treatments and stuff. What do they need to know about that aspect of diving medicine?
Sure. I think the first part is to understand that there are two types of hyperbaric chambers that can treat an injured diver: a monoplace hyperbaric chamber or a multiplace hyperbaric chamber. Monoplace means one person goes in, they pressurize the chamber with 100% oxygen and pressurize that to an equivalent depth of 60 feet. And they do the same treatment table, U.S. Navy treatment table 6 or table 5. Those are the two treatment options. The other treatment option is a multiplace hyperbaric chamber. Multiplace means many people can go in, more than one. That is essentially a larger configuration. It's pressurized with air, and then you're given either a hood or a mask where you're breathing in 100% oxygen. That's also pressurized to 60 feet, and you can get your table 6 or table 5 treatment table. The treatment table itself, treatment table 6, is usually a 4-hour and 45-minute treatment table, and that if your symptoms persist or worsen, the dive physician can increase that time by doing what's called an extension at 30-minute increments. Now, think about this, that if you were in a hyperbaric chamber for almost 5 hours, how much can you tolerate being in there for that period of time? So sometimes either the patient says, I've had enough, I'm getting out, we're done with the treatment table, even though the doctor is suggesting extending it, or they have you come back if you have persistent symptoms for additional treatments. Those are called tailing treatments. And the treatments would continue going on, typically daily, until you reach what's called a plateau. So, for example, I went in with a paralyzed left leg. I couldn't move. I had my first treatment. At the end of that, I had about 50% improvement. I'd come back the next day, and I'd have another treatment. I'd be reassessed, and it's now about 50% improved off of that. After my third treatment, I'm not making any further improvement. The typical dive physician would then probably do 1 or 2 more treatments to see if there's any more improvement. And if there was no further improvement in the symptoms that you have, that would be what we call a clinical endpoint. That would be your last treatment. So that's sort of the difference between monoplace, multiplace. Both can treat injured divers, both for arterial gas embolism or decompression sickness. What your diving community, your listeners, need to know is that in the United States, there are about 8,800 monoplace chambers and roughly 45 or so multiplace hyperbaric chambers within the United States. Many of those hyperbaric chambers, which are in hospitals, are associated with wound centers, and they are not treating injured divers. They're only available Monday through Friday for elective cases, mostly wound care treatments or other medical conditions. And this is important to know because if I, for example, became an injured diver, the first thing I should do is when I come to the surface is get on some oxygen. I should call 911. I should go to the nearest emergency department for medical evaluation, whether it's by ground transport, air evacuation, or ambulance, whatever it might be. And I shouldn't go to a hospital that has a hyperbaric chamber on the assumption that I can get my treatment there, because they may not be treating injured divers. And we would not want you to bypass the nearest emergency department, because it may cause further harm to you because you had a delay of getting treated in an appropriate manner. So go into the nearest emergency department, get the medical evaluation, and at that moment, having a phone call to Divers Alert Network where they can have a conversation with the emergency physician and have a consensus that, yes, this is a diving injury that requires recompression in a hyperbaric chamber. And Divers Alert Network has a inventory of all chambers within the United States and worldwide that are actually available for treating injured divers. So they can help make the arrangement for transferring the patient from that emergency department to the nearest available treating hyperbaric chamber.
Let me share my decompression ride chamber story. I was here, before I had a place here in High Springs. I was down here and I did a cave dive. I actually went to see my friend Jill, had dinner with her. And it was a long dive. It was cold, right? I was diving it wet. My computer cleared. And as soon as it cleared, I got out of the water. Now, that later on, I'm back in my room, and I felt some finger niggles. And I'm like, oh, shiest. I got on O2, called Dan. Dan contacted the hospital for me and then called me back and said, head over to Shands Hospital in Gainesville. They'll be waiting for you. Go to the ER. I went to the ER. So I contacted Dan first because I wasn't like, I didn't get out of the water with a problem. It was like an hour or two later. They actually had to call in the nurse that ran the chamber and a respiratory therapist that was inside the chamber with me. So we did a type 6, or table 6, right?
Table 6, yeah.
Table 6. We did a table 6 treatment. I had no problem. Like, I'm a cave diver. Being in a big, multi-place chamber was like, this was great. I had a bed. They brought in, actually, they said, you hungry? So they got Wendy's from the hospital cafeteria. That was our like breakfast, actually, because it was overnight. That was my story. And my symptoms cleared up like right away. So there was no issues after that.
But, it's interesting, though, that, the challenge in the United States and other parts of the world is that there's a lack of access to appropriate treating facilities that treat diving injuries. And what I mean by that is that you can be in parts of Florida where the nearest treating facility is in Alabama. And you go to the nearest emergency department in Florida, they evaluate you, they then contact Divers Alert Network, who then verifies, yes, they're treating in Alabama. Then you have to be transferred. And there have been cases where there have been, fair amounts of delays in transferring the patients from the emergency department to a facility that is capable of treating you. In the New York area, I live in Connecticut, but there are no hospitals in the state of Connecticut that'll treat a diving injury or diving accident. You would literally have to be taken to New York or Rhode Island or Massachusetts if you had a diving injury.
I know this from being a Jersey wreck diver and crewing on boats. The Brick Hospital in Brick, New Jersey, used to have a monopod that treated divers. Right. I don't know if they still. I mean, and that's the thing, is like, that's why I think it's so critical that you actually do contact Dan, because just don't show up at a hospital that
right.
They have a chamber. Even my issue, they actually had to call in to get a respiratory therapist to come in at 4:00 in the morning. It wasn't like they have people on staff ready to go.
Right. And the other part of this is that decompression sickness is still pretty uncommon, even in divers, right? There's a lot of diving going on, and not everyone gets decompression sickness. So not every symptom that you have is decompression sickness. But as we're aging, right, you could be having a stroke, a heart attack, a diabetic emergency, and therefore getting to the nearest emergency department where they can kind of sort that issue out is important. The other thing to consider is that if you bypass that emergency department thinking that you're going to get to the hospital that you know has a hyperbaric chamber and they're down for maintenance,
Yeah.
they don't have the staff for that day, or the chambers are full and we can't treat you for 6 or 8 hours anyway. Whereas if you started out somewhere else, you may have had that opportunity. But it is clearly it's a worsening problem within the United States of having lack of access to care, and there's fewer and fewer hospitals willing to treat injured divers.
And I know in certain communities, like commercial diving, I just did a story about with a commercial diver in Portugal. Those operations have chambers on site. So first, let's talk about commercial divers. And because commercial divers are basically underwater construction workers, right? So their general level of fitness is going to be that of a steel worker on land,
with the exception that they're underwater under pressure.
Yeah, which is additional.
Yeah, exactly. Yeah. So I think that the answer is that in the United States, the standards or guidelines for medical fitness for commercial divers are based off the guidelines from the American Dive Contractors International, ADCI. Mm-hmm. And they have a medical advisory board, dive medicine physicians, that have recently updated that in their standards guidelines. And it is very clear what that exam should consist of, including an annual exam for commercial divers, that you need a baseline blood test, EK electrocardiogram, pulmonary function study, urine analysis, hearing, and color vision testing. In addition, they look at certain medical conditions that as a recreational diver, you might have been fit to dive, but the standards for commercial diver are much higher, and that may put you at an absolute inability to be cleared to dive. So for example, whereas a recreational diver could actually dive being an insulin-dependent diabetic, a insulin-dependent diabetic commercial diver would be an absolute contraindication. So your requirements, the standards are set where they're very restrictive, and the purpose of commercial diving and scientific diving and military diving as being so restrictive is they have to think about liability to the company, for example, or liability to the mission or the government. So you wouldn't want to have a military diver or a commercial diver working on an oil rig or whatever they're working on and suddenly have a hypoglycemic diabetic emergency, whereas you wouldn't want that for a recreational diver. But if it happened, that element of liability is on, the assumption of liability is on the diver because they've been educated about it, whereas the liability is on and assumed by the company that is employing the commercial diver.
I think, military diving, Navy diving was very much like commercial diving, ship's husbandry and things like that. But now I think there's an additional thing with military divers because even regular Navy divers are now part of special operations. So they not only have to be diving fit, they have to be special operations military fit as well. So that's a whole another level of fitness. But segue into things like public safety diving, because I've done some video work. A friend of mine was was actually instructor for the NYPD dive team, and they're a full-time dive team. But most police dive teams, public safety teams, they're typically police officers, firemen, and I would say they have to have a different level of fitness than say a commercial diver.
Yeah, that's an interesting point. So just so you know, I mentioned that there are definite national standards for recreational divers, for scientific divers through the American Academy of Underwater Sciences, commercial divers, military divers. There are no national standards for public safety diving. Now, you mentioned fire and police as common, but they're also, I would think the majority of public safety divers in the United States are volunteer. Mm-hmm. So on the communities, in the state of Connecticut, if there's a town that has a stream or a lake or a spit of water, they probably have a volunteer public safety dive team consisting of people like me and you who volunteer to be on this that may or may not have that physical capacity if you're a police or fire, you at least have to go through a police or fire physical through their occupational clinic to be a police or fireman. But there are no national standards of or accounting for what is required for public safety diving. There have been attempts at creating that, but there's not enough literature, it has been told to me, to support making those recommendations. In other words, that what are the requirements for public safety diving compared to commercial diving? And I don't have all the answers, but I can tell you that I do work with the public safety diving community very heavily. That's one of my biggest customers, my clients. I work regionally and nationally with public safety dive teams. And we do have guidelines and recommendations, but it's sort of a hybrid between what a commercial diver standard is and somewhere between a recreational diver.
I know I did a video years ago in Middlesex County, New Jersey. We shot this in the Raritan River.
Right.
But it was the Middlesex County Public Safety Dive Team. And it was this really a hodgepodge because there was some volunteer firemen on it. There were some police from different departments and things like that. It wasn't like a police department's dive team. It was sort of like this group that got together. They were at the time, I don't think they had an official training. Like today, there's public safety diving courses. I think they were just like, we're all scuba divers. Let's go look for evidence underwater, that kind of thing.
Yeah, and I think that, being a public safety diver in general, the work requirement is really severe and significant, right? You're diving in brackish, poor visibility, hard conditions. You get the call from home at 10 o'clock at night about a missing car that went off the bridge in the middle of the night when it's 20 degrees, and now you're in the water, even though you just finished a shift at work, right? So you're going in the water tired, anxious, in the worst of conditions. And what is your physical fitness to dive at that moment?
Well, Dave, here's what I think we're going to do. I think we're going to revisit this in a separate episode, and I might be a three-way interview because I spoke to someone at NAUI who's handling their public safety diving program, and maybe we can get this as a conversation. Is like maybe there is a way to set up some standards and protocols for this. So let's revisit this. I think this is a good subject.
Sure.
But before we move on and kind of wrap up here, I do want to talk about another group of divers which probably doesn't get as much attention as they need to in terms of fitness. Let's talk about women divers. Women in diving.
Yeah.
What specifically are their fitness concerns as opposed to, and I'm not saying like you can be an aging man or an aging woman in diving, but is there anything specific to women that is not specific to men when it comes to fitness?
Well, there's a great textbook out written with Caroline Fife wrote a book on women in diving. Blanking on the co-author. There's not a lot of literature out there. There's not a lot of science or data known about the differences or recommendations or guidelines for women in diving. So I don't know that I could make a dive physician statement that, this is what women need to know and men need to know as a separate entity. I think that what I would say is that each person, man or woman, needs to be evaluated individually based on what their medical issues, psychological issues, nutritional issues are, all those aspects to fitness to dive to help determine if they're fit to dive.
Okay, very good. So Dave, let's just wrap it up here. Try to summarize, because when we talked about this actually at DEMA, I thought this was really interesting because, and when I started this podcast in 2005, I remember one of the earliest things I did was me and Carl Shreves were, both gym junkies, started talking about fitness and diving, how important it is to be in shape. So when you mentioned about, from a dive physician's perspective in fitness and diving, I thought this would be a great subject to dive into in depth. But in that, try just summarize what, if this is your elevator pitch, like we're in the elevator, we're talking about fitness and diving, how would you just summarize what we discussed today?
I think that in my mind, when we talk about fitness to dive, or as a diver, when I'm thinking about my fitness to dive, I think about those 6 components, right? The medical fitness, the physical skill, nutrition, the psychological fitness, and my knowledge. And what I'm going to be accomplishing today as a diver. What is in my dive plan for the day? If I'm doing a recreational dive to 60 feet in rarely cold conditions, do I have the appropriate personal protective gear on, right? Am I drying a dry suit? Do I have gloves? Am I well nourished for the day? Did I have to get up at 3 in the morning to get to the dive boat exhausted, and the night before I had a huge fight at home or at work? Emotionally, I'm distraught, right? So I look at these 6 components, and that's an important part of that. And realizing that at any part of our diving lives, right, whether we're young, old, or in between, I may develop a condition, a problem, whether it be medically, psychologically, that may put me at risk, and I need to discuss that with my physician, my provider. And the most important part of understanding medical fitness is trying to be honest and upfront with that medical provider, disclosing to them what your concerns are, that yes, I've got hypertension and diabetes, and I'm concerned that it's going to affect my ability to dive. And then getting the feedback from that physician, and then being able to process it and be able to act on that information. Now, having said that, that requires that the physician you speak with has a knowledge in dive medicine to be able to make an informed decision. And that's always a challenge, right? We know that there are not a lot of physicians or nurse practitioners or physician assistants that are doing these evaluations that have knowledge in dive medicine. And that's important because your listeners need to know that in medical school, in nurse practitioner and PA school, physician assistant school, there are no classes in dive medicine. There's no classes in hyperbaric medicine. There's no education, training, or knowledge. So when you go to your general practitioner for this advice, they may or may not be able to counsel you appropriately. So if it's something that's really meaningful to you or important, then you really need to do a little homework and seek out a physician who has knowledge in dive medicine.
Okay. Now, Dave, you have your own website and a podcast of your own?
Yeah, so I have a podcast, believe it or not, on fitness to dive.
And we'll put that in the links down here.
Perfect, yeah.
And actually, I'm going to write it right across here, your website to your podcast.
Good.
And people can get that there. And that's an audio or video podcast or both?
It's an audio podcast. There are 11 featured discussions from cardiology, heart fitness and diving, lung, pulmonary, ear, nose, and throat. And then I've got some featured, I won't say eye candy, but featured speakers like Richie Kohler talking about his issues that he had to overcome, medical issues to get back to his fitness and diving. At any level, whether you're a high-end expedition leader, I interviewed Fabien Cousteau in his expeditions. There'll always be complications on the journey in maintaining one's fitness to dive and making sure that whether it's a expedition to the Britannica or 30 foot off the dock, getting in the water is easy, but getting out of the water is also important.
You know, I post this as both a video and an audio, but I still love audio podcasts. I know they're like old school, but right. I fly a lot. I'm on a plane 3-4 times a month. I'm always traveling between Audible and podcasts. I find that's a great way to keep informed. Sure. So I love audio podcasts still, even though everyone's watching the video and we're going to add, like the eye candy, but also reminding everyone if they want to listen to Pod Diver Radio, the audio version, we're on Spotify and iTunes and all those other places. You can listen to this as well. So Dave, once again, thank you for this, spending some time with us here. Much appreciated. And I think we might be revisiting in a few months doing a story about fitness and standards for public safety diving. let's
That'd be great.
talk offline about that. I think that'll be a cool story. Once again, thanks, Dave. Anything else you want to say?
Well, I want to thank you, Joe, for continuing to support the diving community. Anything that you do helps us as divers, so thank you.